Hello, welcome everyone to the fifth session of this Patient Family Donor Day. I'm Gillian Adams and I've got fellow chair Lola Manterola, and we're part of the Patient Advocacy Committee and we will be chairing this session. And today we've got two really interesting topics. First, a general presentation about how the donor registry works and how crucial a registry is for the life of all of our patients. And afterwards, we'll focus on pediatrics and pediatric transplantation. How does it work? And then we will listen to the testimony of a donor, in dialogue with the doctor that did the bone marrow transplantation. But first of all, I'm absolutely delighted to introduce Dr. Juliana Villa. Juliana is a hematologist trained in Barcelona and works in stem cell transplantation setting with the unregulated donor setting. And since the summer of 2019, she's been the Deputy Director of the Spanish Bone Marrow Donor Registry. So Juliana, welcome and over to you.
Hello everyone, and thank you very much for the kind introduction. So as Gillian said before, I'm here to speak today about donor registry as a lifesaver and to tell you a little bit about the general Spanish situation. So I do not have any conflicts of interests, and as Gillian said before, I've been working for the last year and a half at the Spanish Bone Marrow Donor Registry. So maybe just to start, a quick word on what registries are. So we are the organizations responsible for the coordination of the search for stem cell donors for a specific patient, but also we can act on behalf of the donor because we're also in charge of recruiting every time new donors and to coordinate the stem cell donation procedure once the transplant center has asked for a specific donor. That means when we act on behalf of the patient, there's a patient in need, they have an indication for an allogeneic stem cell transplantation, and in that case, they didn't have a family donor, and that's why the transplant center asked the registry to make a search in a worldwide database of donors. There are around 38 million donors worldwide, and then once the registry finds that donor, they activate the donation process with the donor registry. And once the donor registry gets asked about that specific donor, they have to do three things. They have first to call the donor and ask them if they want to keep on with the donation process. If they say yes, they need to verify that both donor and patient are really compatible, that that's the right donor for the patient. And once they do that, they would make a checkup of the donor that he's healthy and fit to go with the donation process. And then afterwards, they would coordinate the donation process and the transport of the cells from the collection center to the transplant center. So registries act always both sides, for the patient and for the donor. And I think it's very difficult to speak about the general situation without speaking about the pandemic, because the coronavirus pandemic changed our way of life. And I think the last year it was the greatest adversity we registries have ever lived since there is an international program of donation. And why is that? Because it affected both. It affected the donors. Donors were at home, they were confined, they were in contact with COVID patients, they got sick with the disease, they were afraid to go to the collection center, or they were homeschooling their children, and it was very difficult to organize a donation in that setting. And the same happened to patients. Patients were also confined. They were also homeschooling their children. And if you think transplantations are a very specialized procedure, and it always takes place in hospitals, very specialized, and precisely those hospitals were the ones treating the COVID patient. So it was very difficult to keep on the schedules that were originally programmed for that transplantation. And on the other hand, this pandemic closed all international borders, and you have to think more than half, or at least in Redmo, we export and import over 3/4 of the cells. That means the donor is in one country and the patient is in another country. And if you have borders closed all around the globe, then imagine how difficult that gets. So it was a quite challenging year. And in the summer of last year, the World Donor Association, they did a quick survey just to take a glance at how was the situation for all registries worldwide. And I have to say 74 registries responded this survey, and they asked different questions, like, for example, did you stop activity at any point? And as you can see in the slide, 5% responded they did have to stop completely their activity. Then they also did other questions like which were your challenges during the pandemic. And as I told you before, the 3 main challenges were regarding closing borders and reduction of international flights because of the difficulties in the transportation of the cells, and then also the increase in donor reluctance to donate because they were afraid of the pandemic, and that's completely understandable. They also asked, for example, did your registry lose any product during the transport of the cells? We, thank God, did not lose any products, but as you can see, 4% of the registries responded yes. And for that, I can tell you, for an example from Redmo, we had this product, these cells, that we needed to take them from Lisbon to Barcelona, and we were expecting that to happen in 6 hours. But then when the courier got to the Lisbon airport, and the couriers are the people that are specialized in transporting the stem cells, the flight to Barcelona had been cancelled. So his only alternative was to fly from Lisbon to London and then to Barcelona. But when he arrived to London, the flight to Barcelona got cancelled. So his next alternative was to fly to Amsterdam, sleep over in Amsterdam, and then on the next day fly to Barcelona. But what happened? The next morning, the flight to Barcelona got cancelled. So he had to fly then to Madrid, and then from Madrid by train to Barcelona. So something that was supposed to happen in 6 hours took him 1.5 days. So imagine that when you have to take cells, for example, I don't know, from Chile to Poland, then it's a huge challenge. Then they also asked if your registry provided cells, but the transplant center did not use them. And this is also a very big challenge we have been experiencing over the last 12 months, because, as I told you before, transplant centers are not able to keep their scheduled plans as they usually would do. And sometimes it did happen that the donor has donated himself, but the transplant center was never going to use them because the patient did relapse or they didn't have time to schedule the transplant. So that's another big challenge we have been experiencing. Another very important question: did your registry stop donor recruitment at any point? As I told you at the beginning, we registries are responsible for keeping that worldwide pool of donors alive, to always have new donors. And if we stop recruitment, then this pool can become always smaller and smaller. And as you see here, over 90% of registries had to stop face-to-face events. So the things we do on the street, the donor drives and this kind of recruitment, and that had a big impact also on the registry's strategies. And which solutions did we find? So many registries started to work from home. We did that at Redmo. We had a lot of luck because everything worked out from day one. So we have been home working since the last 12 months. The different governments also came together with the international regulations, and we managed to get a waiver for the couriers that were allowed to cross borders without any problems. There was also very important the constant communication between registries. I can tell you, you might remember that the first wave of COVID had a huge impact in Spain, and we were just a few weeks before Italy's experience. And I can just but thank Italy, because they were so generous. They were going such through such bad experience, and we were constantly asking them, how are you managing this? How are you doing this? And their feedback was an immense help for us to get really set up for what was coming to Spain 3 weeks later. So that was very important. The WMDA, the World Marrow Donor Association, also created specific task force to help registries on transport, on selecting cord blood units, and many others. Then another solution different registries found, it was for the couriers not having to go inside the country once they arrived. They put hubs at the airport where they could hand over the cells from the donor registry to the patient, and then the staff from the transplant clinic or the processing lab would go to the airport and pick up the cells from the courier. Other solutions were, for example, charter flights, so special airplanes for only transporting those cells. We also used alternative couriers like pilots, or as I said before, personnel from the TC, from the transplant center. We also did alliances with couriers and government institutions, and we turned everything virtual. We celebrated here in Spain, we have the Patients Week. So we celebrated, for example, the special week online, and we did the same on the Donor Day. And just to show you some of the results of REDMA, an example of what was last year, here you can see the total numbers of donors in Spain from 1994 to 2020, and you can see we managed to enhance the number of registered donors in Spain, even in the face of the pandemic. The growth was not as in years before, but we managed to keep having more donors. Here I am showing you the number of effective donations compared to 2019, and you see we only had one donation less than 2019. And here, if you see March and April, you see how bad the first wave hit Spain in terms of donations. But then you see when the wave got better, then these donations got better too. And then you can see the different waves in the number of donations, but we managed to keep the donations in place. And what happened to the transplantations? I used the word here transfusions because here I'm speaking of all kinds of products, peripheric stem cells, bone marrow stem cells, and also donor lymphocytes. And we did experience a 5% drop. But if we would show here the numbers of the products that REDMO was allowed to take from the collection center to the transplant center, you would see we even increased that number, and the transplants didn't take place because of the saturation of the hospitals. So, which are my conclusions? That teamwork has never been so relevant. It is even today very, very important that all the different transplant centers, collection centers, registries, courier companies, that everyone that works in the setting works together. IT has never been so crucial. We're seeing now other EBMT. Now everything is virtual, and to have this has allowed us to keep on the activity just as we had in years before. I think we own a huge thank to the different courier companies, but because what they have doing for the last 12 months is just amazing. And I really think all the stakeholders involved in the allogeneic non-related transplantation program are the real lifesavers. I think everyone involved has done such a great work for the last 12 months. And I think that's the most important conclusion, that even in the face of the worst adversity, we have been able to keep the stem cell program alive and running, and patients have been receiving their cells. And I think that's great that we can share this experience with you. So this was my last slide. I thank you very much for your attention, and I'm really happy to take any questions later in the Q&A. So thank you very much.
Diana, this has been really amazing, just to know all the difficulties that you had in the registry for, in the time of COVID, and the problems with transport, and congratulations for such a great effort between, a team effort between all these different parts. So please write any questions that you may have, and then we will and try to answer it later on in the Q&A session. So now it's a great pleasure for me to introduce Dr. Antonio Pérez-Martínez, Head of Pediatric Hemato-Oncology Department at University Hospital La Paz in Madrid, and also Associate Professor and Chairman of the Department of Pediatrics at the Universidad Autónoma de Madrid. So also I would like to introduce Daniel Guerrero, who is a donor and a father of a leukemia patient, Isabel, and later on we will have a dialogue between Antonio and Danny. However, first I would like please to give the word to Antonio, because he will do a presentation about pediatric transplantation and how does it work. Please, Antonio.
Thank you very much, Lola, for your kindly introduction. And thank you all of you for giving me the opportunity to share with you some thoughts and things about pediatric transplantation. Well, the title of my talk, it's called How Does It Work? It is a positive way of the talk, because we already know that sometimes pediatric transplantation, it does not work as we would like to work. But we are going to talk about the positive situation today. Let me go ahead my talk. I have divided in different topics. As you can see, I have a note disclosure for this topic of today. I have divided my talk in these 4 different topics. First of all, I would like to talk just a little introduction regarding the pediatric transplantation. Then I would talk about the activity of the pediatric transplantation compared with the adult transplantations, some singularities of the pediatric transplantation, who makes that it had to be a specific pediatric programs for transplantation. And last but not least, I would like to talk about some open questions that still we have in the field. Well, regarding transplantation, all of you know that many colleagues consider one of the most complex medical procedures in the medicine nowadays. There are many pediatric medical lethal conditions that only can be cured with a stem cell transplantation. As you know, the father of the field is Dr. Edward Donald Thomas, who acquired the Nobel Prize in the 1990s. And it is a very highly specialized processor that needs a very improvement in the quality units, concentration of the knowledge, and a high expertise in the field. And it's not a closed treatment. It's a dynamic, active, and open and continuous treatment, because we still want to improve the cure rates, but also we want to improve the cure rate with less side effects. And also, of course, in the pediatric setting, we have some specific singularities. If we take a look in the overview of the stem cell transplantation, it started in the last century in the middle of the last century, from the US, from the people from Seattle. The first 2 decades of development of this processor, it was very hard for them. And 20 years later, after the first transplantation, many colleagues said that this procedure was useless. However, Donald Thomas awarded the Nobel Prize 20 years later. Many people are cured because of this treatment. Now we are in the era of the cell therapy, and we are now going on from the bone marrow to the cell therapy in the field. We know that we have many different sources of progenitors, not only bone marrow. We also have cord blood. We also have mobilized peripheral blood. We now have many different donors, not only matched donor. We also have alternative donors with mismatch, HLA mismatch settings. So we now have many drugs. We have many conditioning, so we are now in a very dynamic procedure because we are looking for the new strategies to improve cure rates with less side effects. As you know, in the transplantation, it's not only one phase. We can divide it in 3 divided phases. The first one is the pre-transplantation phase. In this pre-transplantation phase, we have to consider, of course, the donor. We have to look for the donor, but also we have to take care of the patient, because it's very important to take a healthy patient. It means with a controlled disease. If it is a malignancy, we have to be able to have a deeply remission of the malignancy, to have a better outcome after transplant. But also we have to try to identify any comorbidity that can improve in the post-transplantation setting. So this phase is very important because we have to take care of the patient, but also we have to select the right donor. And the right donor is not the same from a patient to the other, and it's not the same from a condition to other condition. Later on, we are in the transplantation phase. The transplantation phase is when we infuse our cells. We have to decide which conditioning, which GVHD prophylaxis, which donor source, which graft cells. So there are many open questions that can be different and make different from one donor to other. And then when we infuse, we start. It has no end. The transplantation is started in a new phase, we call the post-transplantation phase, when we have many different situations. Some of them could be very aggressive disease or secondary disease. For example, rejection. Rejection is the first problem you have to overcome. It could be acute or could be chronic, and it depends on the disease, depends on the conditioning. So that there are many different challenges in this situation. But also we have the GVHD. We have the graft versus host disease that we have to consider because although in some situations we can be controlled, in other situations we cannot control, and this is a reactivity that we are looking for to be cured for the patient, because the graft versus leukemia effect can also have very high problems with the patients. Of course, in this immune reconstitution processor, we have opportunistic infections and virus reactivations, and also we have problems related with the drugs we use in the conditioning. You know that some alkylating agents can induce damage in the liver or damage in the endothelium, or TBI, who also have considered GVHD and liver damage. Also, we can have PTLD. You know, there are many different problems after transplant in the first month, but until 1 year, until we have immune recovery of our kids. So it's not surprising for us that when we ask to the parents how they feel when we talk about transplant, most of the 50% of the parents reported that they think it's going to be a difficult situation for his child, but also for the parents. So this is a survey, very important, and very few reported thoughts about adverse child health outcome, because we have to consider that still there is a situation called transplant-related mortality, that it depends on the type of donor and the type of the disease and the situation of the patient could be as high as 20%. So this is a very important topic we have to address in the first phase of the topic with the parents. Regarding the activity of stem cell transplantation, as you know, pediatric transplantation is 10% of total activity in Europe. You know, there are at least 4,000 transplantations per year in the pediatric setting, and as you can see, more of the transplantations of our transplantation are allogenic. 3 or 4, 75% of the transplant we perform are allogenic, while in the adult setting, the allogenic and autologous transplantation are half, are 50-50. And the indication of that is because we transplant more acute leukemia, and acute leukemia, myeloblastic and lymphoblastic, autologous transplant has no role in this disease. So most of our transplants are allogenic. We also transplant many specific pediatric diseases, as we call the immunodeficiencies, some metabolic disorders, and also this is the reason why most of the source we use are bone marrow for this disease, and also we have an increase in the haploidentical donors in our field. So these some particularities if we compare adults transplantation versus pediatric transplantation. This is something that it's increasing not only in adult but also in pediatric. There is an increase in the haploidentical alternative donor with haplo, and a decrease of the cord blood also in the pediatric settings, and we mimetize what happened with adults. You know, if we take a look in Europe, we can see that there is a homogeneous presentation of all of these pediatric programs in the allogenic, in the autologous, and in the cord blood, and also the proportion of the pediatric disease we transplant in the allogenic in the autologous setting are also very homologous in all the pediatric programs in Europe. As you can see, most of the kids are transplanted in pediatric center. This is a very important topic to me, and this is the reason why pediatric should be transplanted in the pediatric programs that can be shared with adults, but most of them have to be by pediatric stem cell transplantation experts in the field. Which singularity we can talk about the pediatric setting? Well, one we have talked about that. One of them is 10%. It's less frequent than the adults. We have some specific disease. We transplant more bone marrow source as adults, and we also have an increase of the alternative donors, for example, the haplodonor. But if we take a look in the 3 different phases, I talk in my first slide, we also have said that we have not a specific risk score to identify which kids are going to have problems in the transplantation phase. You know, our kids, most of them, the risk score cannot predict what is going to happen in the post-transplantation phase. So we have to be very suspicious with our kids because we still do not have nice tools to identify in the transplantation phase what is going to happen in the post-transplantation phase. And also, our kids have the chance to be transplanted with very high intensity conditioning. And this high intensity conditioning, it means high cure rates, but also high acute or delayed toxicity. So it's something we have to try to address, and I will address in the next slide. And of course, the post-transplantation phase, kids have a great opportunity to induce immunotherapy approach and try to induce boost approach. Why? Because most of our kids has thymus. Thymus is a very important organ that adults we do not have. In the second decade of the life, we lose these organs, and kids, most of them, they can have this thymus, and the thymus can help us to develop boost strategies and boost immune system, as we explain later. Side open question we still have on the field is regarding conditioning. Recently, we have a prospective, very nice study, a randomized prospective study, that we said that when we transplant malignancies at acute lymphoblastic leukemia, that is the most frequent disease that we transplant in our kids, they said that when we use myeloablative conditional regimen, TBI, we have very high rate of cure, 2-year overall disease-free survival of 86%. However, we also can tell you that 18% of these patients in the upcoming year, they are going to have second tumors, and they are going to have very problems regarding neurological effect, metabolic effect, neurologic effect, and also metabolic problems in this setting with TBI. But when we compare with non-TBI, with, for example, busulfan or coflarabine, we have to consider that the 2-year disease-free survival is going to be at least 50% less, but we are going to have less side effects, we are not going to have second tumors, and we cannot also develop immune effects. So there is another point of view that I would like to talk, because conditioning is important in transplant, but also the graft and cells are also living drugs, and also they have a potent anti-leukemia effect with less side effect. This is not a new story. This is an old story that started with Professor Mate in the middle of the last century, and it was continued with Professor Storff and Professor Belardi, and of course Professor Hangrettinger and Professor Liyun, who were my mentor, and they developed how immunological competent cells have the chance to eliminate residual leukemia cells, also adoptive T cells and NK cells. With this approach, we can, for example, reduce the toxicity of the conditioning. As you can see in our hands, we have 70% of 2-year disease-free survival with very low effects. However, if we want to improve this overall survival to 80% as the same of TBI, we need to still to boost the immune system with cell therapy after transplant. So post-transplantation phase is very important in this setting. So in summary, in the open question, how does it work, transplantation? It's something we have to consider the malignancies, we have to consider the conditioning regimen, we have to consider the patient and the donor, and we have to consider that the post-transplantation phase, in some cases, is a great opportunity to boost immune system and to induce graft versus leukemia effect in our kids. Of course, now we are in the phase in the century of the advanced cell therapy in the CAR T cell. So what is going to happen with our field with transplantation and CAR T cells? Can CAR T cells mitigate or eliminate transplantation, or we have to synergy transplantation with CAR T cells, and how CAR T cell before transplantation, CAR T cell after transplantation? Well, these are still open questions we would like to address in the next years, in the upcoming years. So this is my last slide. Let me introduce this patient. This patient is Isabel. She was acute myeloid leukemia patient with only 6 months. Yes, she developed with the disease. She has a very aggressive myeloid leukemia, a very aggressive cytogenetic disease that unfortunately it responds to chemotherapy, and we consolidate with haploidentical donor with an immune boost strategy. And now, you can see, she's a young lady, a beautiful young lady with open, with all the future energy, with a very healthy. And now, is going to speak his father, Danny, who is also a friend of us. So thank you very much for the opportunity to tell today in this Patient Family Day. I'm happy to take any questions. Thank you.
Thank you so much, Antonio. What an interesting presentation, and all this. We are really happy that professionals like yourself are really looking for getting ameliorate all the treatments and transplantations procedures. And now we have a great opportunity, because together with Antonio is Danny, which is the father of Isabel, that is there on the beautiful girl that is now cured thanks to this transplantation done by Antonio. And I would like to have them, both of them, together in the screen, and have first I'm going to ask a question. So we'll have 3 questions that we will ask them, and we would like to answer from the doctor's point of view and from the patient's point of view. So a patient or family, in this case, family member. So first question will be, how do you face the time or the phase before transplantation? When the patient is diagnosed, and first as a doctor and then as a father in this case, what are the recommendations that you give to the audience?
I don't know. Okay, now we are together. We put on our mask because we have to respect the social security distance. Well, yeah, the pre-transplant thing is very important. You have to trust on your team. You have to trust in your transplantation colleagues, in your doctors. You have to talk. You have to have a very, very sincere dialogue with him, asking all your doubts, talking about all your questions, and try to identify that is not going to be a short course. It's going to be a long course. You have to be very, very during a while, the hospital is going to be your family, your new family. So all of us, we have the same objective that the family have, is to cure the kids with less side effects. And sometimes it works, but sometimes it doesn't work. And in both cases, we are trying to do our best. There are many decisions we have to take every day. For example, donor selection, source selection, type of conditioning. Many times it's not the same that in the room who is close to you, because parents used to talk and why to me is different to the other, and it works, it doesn't work. So this kind of relation, it is not. It's very important to consider that each transplant is different, and you have to trust on your team, on your transplant field, and you have to be sure that in the hospital you are, it is a good hospital in the field, because they have experience on that. They transplant many kids like your kids, and also they have accreditation. For example, JC quality accreditation. It is something very important now in the field, because it gives you like a security that you are doing the best for your kids in your hands. So for me, in my dialogue with the parents, it's very important this first interview, and try to imagine different scenarios that can happen after that, after some months later. It could be optimistic scenario, but also we have to consider that there are many problems, and many problems can impact in the life of the kids. I don't know, Danny.
Yes, well, thank you for the presentation, Lola. Hello, everybody. I'm here. I'm happy because I have my daughter 8 in the morning with me. Wake up together, and this is for the research. Pre-transplant, when the doctor tells you that your daughter only child that living depend on a transplant, your first thought is what the probability of survival is, and which effect she will have in the future. You wonder if she is at the best hand, but you don't know. Everything is quickly. If the medical team is not prepared to proceed with the transplant, is she in the best place to be treated? This is a important question, and maybe the life of your daughter is in this decision. No, I know that we were in the best place and with the best professional, but I think, Lola, that it's necessary to know the only thing, the only can do a thing for a child. You have to look for the best hospital with the most advanced treatment, with a certified experience in similar case, and with international certification like a JC. This is the only thing that you can do for your daughter, for your kid, for your son. And now it's necessary to know who is the the medical team, because it's important. Speak with them every day with clear and hopeless, and you have to know that your daughter is in the best hand. Is probably is the only thing you can do.
Thank you very much. So the second question will be, how do you face the transplantation time when it's happening? What are the recommendations that you will give as a doctor and as a family member to the audience?
The transplantation phase is when everything started. I mean, for the family. I talk later that the transplantation phase is very important, but transplantation phase, everything is going on. So the first thing would like to say, okay, we are now on the way. Trust on us, and for us it has already started. The transplantation has not finished when we infuse the cells at day 0. Everything starts. Everything starts. The hope also starts at this time. We have to be hopeful, but also we have to take to consider that we have to work very close to the nurse and very close to the doctors, because family and parents are taking care of his kids all day, and they can help us a lot to identify the first problem, to identify. So we are a team. We are a team. We think and we have in our mind everything that can happen. But for the family, we also give them the power of help us taking care of the kids. Very, very, very important to take clean the room, to collaborate with the care of the kids in the bath. All of these things have to be taken care of in consideration with them to try to make a friendship atmosphere, like a family, because then we start with the great challenge we have. So at that time, it's very important to be very close and try to eliminate any problems as soon as the problem happens, because then if we eliminate and we talk with the problem at the beginning, then we can go up, and the trust is going to keep during all the transplantation setting. This is for me the most important thing. Dani?
Yeah, I think that you is like one member of the team, or for the medical team to get the best option for your daughter. I think it's essential to have hope and to be positive with the treatment. For me, it's necessary. Trust the medical team is the most important, because you are you don't have to be feeling guilty that you don't be or to chase to choose the best option for your daughter. During the transplant, you live a constant stress. There are a lot of complications that you can occur. You forget your relationship, your work, and you only think about spending every time with your child. It's really important that your child see you with a smile always on your face. You transmit your energy all the time, especially with the other child. They cannot your worries. It is also very important to have a psychological help to be okay and have a positive perspective of the situation. It's absolutely necessary. I think that this is essential to have hope and to be positive. Trust the medical team, the most important for me. My trust for Antonio and the team is 10%. And this is significant a good communication between the parents and the doctor is necessary.
Thank you so much for these good advices. And very quickly now we have to go through the last question, but we have to be fast because we have now the time of the Q&A, and there's already some questions for you. But just very quickly, your recommendations on the post-transplant time.
Post-transplantation phase, it's a very important phase because when things and it's a long phase. I mean, it doesn't finish post-transplantation phase when we discharge the patient at home. No, it takes a long time. This is the time where we are always thinking in, well, relapse can come. We have to be very suspicious with that. Okay, everything is going good until now, but we still do not finish the race. It takes a long time. So, I mean, we have to be very suspicious in that time. Of course, we have to live and we have to be very optimistic, but we also have to take in consideration that when you are transplant a malignancy, the malignancy can appear even when you don't think that it's already cured. So it's very important that okay, these things going fine, but we have to be very, very cautelous with your thinking. And the other thing very important for me, when things do not work, when transplantation do not work, and you have any complications or life-threatening complications, you also do have to be very confident with your team. You also have to trust in your team, because in that situation, for doctors, for nurses, for all the people who work in the hospital, it is also a big issue to us. We are very aware of that. We are taking care, like when things go wrong or when things doesn't work. For us, it's also a big issue and a big challenge, and we are also would like to consider how can we change that situation. Sometimes we can, sometimes we can't. However, our effort is the same when things go right and when things go wrong. This is, for me, something that family have to be and consider that we are 100% in both cases.
Yeah, and quickly, I think that if the transplant is successful, you must know it is not the end of the illness. It is the beginning on a new phase. It's necessary to know. The fear of relays is constant. You learn to live under the sword of Damocles in your neck. There is a monster. It's a monster in your head that you remember, who remembers you all the time. The illness can come back, and your child can die. It's really difficult all the days. The time pass, and every day, month, the year is a present, because your child has more possibilities. And in the end, it goes wrong. And I think the most important is to avoid the feeling of guilt. It's necessary. And I think the parents are essential, supporting charities and getting resources for the medical team. Thought research to save the future children with the same illness in the future. We have to fight together, and we have to help the doctor and all his team. No more.
No more. That's all, folks.
Hi, oh gosh, what interesting presentations. Thank you, Juliana, Daniel and Antonio. We had 61 participants in this session, and I've got so many questions. We won't be able to get through all of them. But Daniel, I want to start with you. I thought your presentation and your talk around how you've dealt with being a donor and those feelings towards your daughter really brought tears to my eyes. So thank you so much for your really honest presentation. So Daniel, just two questions for you. First of all, what advice would you have to any other parent who is considering being a donor for their child. And then the second question was, how you talked about the feelings of guilt, and one of our participants said, how did you deal with those feelings of guilt? So back to you, Daniel.
The second one is, I think it's necessary don't to be guilty, because I think that you only can do one thing to help your daughter in this case, is to know the knowledge, to choose where is the best team for the treatment for your child, for your daughter. I think it's the only that you can do for her. I think it's necessary, and for the other parents that it's in the same case, in the future or in the present, you have to choose correctly. It's necessary. You have, like I said, to have all international certification, like in this case, a JC for the transplant or something like that, is necessary. It's the only that you can do for your child. And the first it's
an advice for parents that want to be donors. What is your advice to be a parent donor?
It's necessary to be donor, to be in the RETMO. It's necessary because it's something that you have to do. Now I know that it's necessary, but when my daughter was not with the chemio, and as well, Juni is please, everybody, you have to be in the RETMO, because you can help a lot of the child, and you have to trust in your team. You have to trust in RETMO. You have to trust in the research, and to support the system.
Daniel. Thank you, Daniel. That was a really great answer. Thank you so much. And my next question is for Antonio. So Antonio, Daniel was the haplo donor for his daughter, but we've got a question coming through. Which family members are suitable for haplo? Is it just parents, or could it be grandparents, siblings, or wider?
Thank you very much. This is a great question. At this time, when we are treating kids, we have the chance to type in not only parents but also grandparents. For example, we have some experience. We have transplant with some from grandparents because it was not old enough, so we were able to do that. So at the beginning, we have to consider to type in only closest family. I mean, parents and sons and brothers and sisters. Why? Because in most of these cases, for example, in malignancies, we are able to detect if this haplodonor is going to have any alloreaction that can improve graft versus leukemia effect. In more than 95% of the situation, you can identify this in the closest parents. However, in some cases, we have to go to the grandfather or also the aunts or even the uncles. For example, we also have some experience with some non-malignancies that unfortunately we did not find any match unrelated donor for a PID, and we cannot transplant with the family because both of the parents have the mutation. They are carriers of the disease, and we have to look for a haplo donor, and this is the aunt of the uncle. So the doctors are going to tell which haplo donor we have to look for. So the first step is always parents, but if parents and brothers, sisters are not enough, maybe we have to move to the grandparents, uncles, or aunts. So it depends on the disease, and it depends on other factors. For example, as I explained, the two different situations.
Hello. So I've just been told we've got time for one more question. We can run over. And Juliana, this question is for you. We had lots of comments coming through. Really fascinating presentation on how COVID has changed the way that cells are transported. And the question for you, Juliana, do you think this will change forever the way that cells are transported around the world, the experiences of COVID?
That's a tricky question, Gillian. I don't know. Because, as I told you before, cells right now, most of them, when they get to the transplant center, they've been cryopreserved, they've been thawed, and they are stored that way. And then the patient starts their prep for the transplantation, and then they get infused. But if this is here to stay, I can't answer that. It's a very tricky question, because as you saw, the contrast side of that, of doing this, is that some products, some cells are not being used. So this is very difficult to answer today, but I wanted to say something to all the patients and donors. I think today we have a very good situation for transplantation. We have a huge pool of donors. You have the family donors and you have the cord blood units. So I think the positive result of everything today is that almost every patient will have a donor, a family donor, an unrelated donor, or a cord blood unit. And I think that's the message I wanted to transmit also today to everyone.
Thank you, Juliana. Thank you, Juliana. And yes, you're absolutely right. So my husband had a matched unrelated donor, and he's from an ethnic minority where it was very difficult to find a donor. So it's really encouraging, I think, for all of us, all 61 of us on this call, to understand that, you know, technology and medical advances have really moved forward so that haplos and cord blood now are a real opportunity. So just with a minute left, first of all, I just want to thank Juliana, Antonio and Daniel for such interesting presentations, and I do hope that we can all meet again next year in person and enjoy a glass of wine. Thank you everyone, and goodbye.
Thank you.
Bye-bye.
Bye.
Bye. Goodbye.